The treatment is guided by how active we think the disease is. Again, you don't necessarily have to have X-ray damage. Again, the X-rays might be normal. So we don't base it on that. We do use, at Hopkins, we will usually use international standard ways of measuring disease activity, which means the patient will fill out forms, many forms, but we also will do our own general assessment, of course, by history and exam. The doctor will do the history and exam as part of the assessment. So this big global decision if the disease is active will guide us to treatment. So not everybody who has the disease needs to be on the anti-immune medicines. For people whose disease does not appear to be active, treatment might just remain to be anti-inflammatory medications and a lifelong steady program of back strengthening, stretching, flexibility, and mobility. If we determine the disease is active, the disease should be treated. And the treatment beyond anti-inflammatories and beyond if they have failed, that means if they haven't worked, 2 anti-inflammatories haven't given them comfort and their disease still is determined to be active, they should be given the options of taking a biologic therapy. And the usual biologics that we start with are anti-TNF. And TNF is a type of protein molecule that's really important in rheumatic inflammation, particularly in spondylitis and in spondyloarthritis. The anti-TNF include many. There are 5, with infusions there are 2 infusion anti-TNF, but typically it will be a self-injection medicine such as adalimumab, which is also called Humira. But there are several others that can be used, and that will generally be the first biologic. There is some current interest in looking at another class of biologic that might be the first to be used, and it's not an anti-TNF, and it's an IL-17 called secukinumab or Cosentyx, and there is some interest in using that perhaps as the first-line biologic. That's also a self-injection drug. There are other biologics if these can't be tolerated or if there are major side effects or if they don't work. There are other newer classes of biologics that are currently used. There's ustekinumab, which is Stelara, and then there are some others that are used somewhat more in the peripheral spondyloarthritis, those folks who might have more peripheral outer joint arthritis, but may be used in spine. And those second-line or third-line biologics might include apremilast, which is Otezla, and ixekizumab, which is another class of biologic which is used primarily for psoriatic arthritis. So the biologics would be the medications to be used in addition to regular anti-inflammatories and a steady program of stretching and flexibility. Now, unlike rheumatoid arthritis, spondyloarthritis and ankylosing spondylitis, really it should be a very important feature of treatment is this flexibility program, this stretching and mobility. Gentle yoga is very good. Very often we'll send patients to physical therapy at least once or twice for self-instruction because this should become a lifelong regular program. Because the hallmark of this disease is not just pain, but is stiffness. And as I have mentioned earlier, it is, if it continues to progress, the progression might lead to a very stiff spine. And it can be overcome to some extent by keeping mobile, by keeping flexible. And that can be done every day if possible. And we want patients to understand that's part of the treatment.